This is the video of a canal wall down mastoidectomy for an attic cholesteatoma. However, in this particular instance, we will focus more or mostly on the soft tissue dissection work in the mesotympanum and the and the epitympanum as compared to just the drilling. Now, while mastoid drilling is something that one can learn from actual clinical cases, as well as temporal lobe dissections, temporal bone dissections, which is now quite common all around, including simulations. The actual soft tissue dissection inside the mesotympanum, with regards particularly to cholesteatoma, is something that most dissections or most simulations fail to achieve. So, in this instance, we see that while a canal wall down mastectomy has been crafted with a low facial ridge. Now, what we are left with is uh, persistent disease or cholesteatoma in the attic region. And right now, we have an intact incus with either an engulfed stapes with the epithelium or an absent stapes. We don't know, and we have to clear this disease. And what is most important here is both the stapes and the foot plate, as well as the facial nerve, the tympanic segment and the genu of the facial nerve, the tympanic, where the facial nerve transitions from the tympanic to the mastoid segment. Now, this particular part of surgery is obvious to say ignites a lot of fear in the younger colleagues, and that is why also we see a lot of disease remnant and residual disease and residual cholesteatoma in this portion of surgery. You have the lateral semicircular canal, you have the facial nerve, and you have the stapes. So now what you'll see is we are seeing disease medial to the incus. We are seeing us dissecting the short process. Now, as of now, we don't know whether this is cholesteatoma or this is just a large bulbous dehiscent facial nerve, which could very well be there in this part of the region, while one could see from CT scan, but surgical visualization and confirmation remain paramount. Now, with gentle mobilization, more or less, we get an idea that this is not a bulbous facial nerve. Also, one can see landmarks of the fact that we are, though we are medial to the short bursts of incus, but on slight mobilization and contact, we see that the epithelium starts to give way. But we do not know the status of the facial nerve medial to it. So, what we'll do is we will clear the incus, remove the incus from anteriorly, as well as the head of malleus by using a malleus nipper. We assume that some remnant of the head would be attached to the incus. And what you are seeing also is we are using a very thin suction, a controlled suction, because a large or an inappropriate suction is very often the cause for damage to the facial nerve and to the stapes. And you'll see us mostly in this part of the intricate part of the surgery as using less of blunt and more of sharp dissection, because this way you reduce the traction on an inadvertently missed dehiscent facial nerve. Sometimes the granulations could be affecting the facial nerve directly. So sharp dissection obviously is much more advantageous than blunt dissection, which leads to a lot of traction trauma. So here you see we are removing the fused ossicular heads with some portion of the malleus head and the body of incus, and we have resected it using a various nipper. And now what you see is cholesteatoma. It is lying at the level of exactly the level of the genu, and this is very important to clear it completely without traumatizing the foot plate and without traumatizing the facial nerve, because dehiscence of facial nerve is very, very common in this segment, even if the CT fails to demonstrate that. And so at any point of time, once we are dissecting, especially in the genu segment, whether it is granulations or actual cholesteatoma, one must assume dehiscence unless until proved otherwise. So you see how we are using a sharp dissector mostly, either a micro iris scissors or a sickle knife, to gently give downward pressure onto the epithelium to keep pulling it off the facial nerve. And as you pull it down, now you start seeing the actual facial nerve, which is still not completely seen, because if you see, the facial ridge has still to be thinned from the anterior portion, that is the mesotympanic portion, because we are unable to see in the posterior mesotympanic recesses. So at this point of time, the visualization of the posterior mesotympanum must never be compromised. One mustn't do surgery without seeing. So before one goes forward or one goes ahead, An appropriate sized diamond burr under ample irrigation must be used to even lower the facial ridge hair as well as to thin it from the anterior portion to be able to achieve an adequate view of the posterior mesotympanic recesses as much as possible. That ways, one can be sure of not missing any epithelium inside this region, and one because if one does so, that is almost a sure shot recipe of having a recurrence. And very often people call this recurrent cholesteatoma, though there's hardly anything called recurrent. Mostly it is residual cholesteatoma. Recurrent is only in long term if you have had some patent deep recesses in the drilled mastoid where epithelium starts to collect again, and that could truly become a recurrent cholesteatoma. Otherwise, mostly it could be residual disease. So now you see you have the landmarks in picture. You have the lateral canal bulge right in front of you, and now we are very gradually and with very measured movements dissecting the epithelium from the facial nerve, and you're seeing how in between we use either a scissors or a sharp dissector like a sickle knife and not a blunt dissector, because what we don't know is the level is the status of facial nerve, and we certainly do not want a lot of traction to come on an intact facial nerve, dehiscent facial nerve, because that can lead to some paralysis, even if it is transient. Now, once you see, we are gradually using different sort of instruments. One can also use a whirlybird dissector, which is turned towards a certain side. But you see how epithelium now can be differentiated from the actual facial nerve. So we are using a thin suction that is appropriate for this kind of work. The dissection must happen from superior to inferior and from posterior to anterior. This is what the convention says. This is to avoid traumatizing both the facial nerve as well as the oval window, because if inadvertently you use too much pressure or traction on the stapes region, then an intact foot plate scenario or intact stapes head scenario, this can simply give way into a foot plate fracture or worse, an avulsion. Now, see here, we don't know what our palpatory instincts here make us feel is that there's some remnant of the stapes, and certainly not a complete stapes, but with some remnant of stapes. Like you see, we are still resorting to sharp dissection and not completely blunt dissection, because we want to be very sure that we do not cause a subluxation of the foot plate, which can be very unforgiving in patients. And you see how, with a very light traction, with a thin and appropriate suction, with the sharp dissection, we can start getting the cholesteatoma sac en bloc from this very vital region of the second genome of the facial nerve. And we have seen a lot of times that despite adequate drilling experience, a lot of photologists who are in training or who are young often are very apprehensive about this step, and rightly so. There is reason to be apprehensive, but of course the point is to develop strong processes and techniques whereby disease from this region can be carefully addressed, with thus avoiding residual cholesteatomas in this region. We see how we are still lowering and thinning the facial nerve right sometimes to the level of the actual sheath of the facial nerve, because we have to clean the disease no matter what. Cannot leave disease behind. And now you start seeing the tympanic segment of facial nerve once this epithelium or this cholesteatoma has been completely removed. And also we have removed the remnant of the stapes, because there was no actual head, there was just some remnant of the capitulum inside the epithelial sac. And now what you see is an intact tympanic segment that transitions into the vertical segment, and absence of stapes head, and only a foot plate region. And the purpose of this video was to basically explain and elaborate the soft tissue dissection techniques in this part of the mesotympanum, the posterior mesotympanum, which needs to be separately addressed apart from just getting through the techniques of bony drilling. They are separate, and soft tissue work is quite separate.